Good afternoon, everyone. And it's my privilege to be a part of ISCCM for session today for the initiations taken for the STEP EN program. And I would like to thank ISCCM Academic Chair Committee, Dr. Ramesh, is the head of critical care medicine at Continental Hospitals, and Dr. Saud is our moderator for today, and Madam Bobby Ramesh is the director of nursing. So before myself moving on to the topic, I would request all the um, audience, whoever is there, between this 45 minutes of session, what exactly you're expecting out of this sessions. So you can just comment, or in the chat box, you can give your recommendations so that we'll start up with the session. Another 1 minute we can wait to have your response. If not, I would like to get into the session, what exactly we're going to say in this session. Okay, so if the speaker, I would like to tell you about my own expectations when I'm a learner. I would ask 5 questions before starting or reading a session. Always we look for why this particular topic is an important for me. When do I need to implement this? How do I need to implement? Where do I need to implement? And how I would be able to present in my during live sessions. So you should be able to see in this objectives, that is what exactly I quoted. You can look into this. Why is this culture sensitivity is done for the patients? How the sensitivity testing is going to be conducted on the patients? When should be the test to be performed? And what kind of samples are collected? And how do we prepare a patient for this particular test? And how are the results reported? And results for a sensitivity analysis is done, and why is the sensitivity analysis is done for the patients, and briefing on antibiogram. This is the important objectives and which are going to be answered to you between this 45 minutes of session. So the first question I can tell, that is what is the culture sensitivity, and we should be able to get two answers in this: what is culture and what is sensitivity. So come to a culture, it is a test to find out what type of exactly germ it is, whether it is a bacteria or a fungus that is causing an infection for your patient. You should be able to do culture. And what is the meaning of a sensitivity? Sensitivity always a test or checks to see what kind of a medicine which will be useful for your patient for his betterment, or a treatment or illness gets better if they take choose an antibiotic. So why to do this particular test? As a physicians, all of them very well know, before coming to a conclusion, they always ask a nurse to do a particular test. So that test will be sent to a lab to do a culture and sensitivity. So it is mainly to help in diagnosis of an infection if they have a symptoms of any infection, or in order to identify a targeted treatment so the patient can get better faster. So you know, why is the sensitivity test is done for your patients? So many of the bacteria are very resistant to your common antibiotics, whatever is used. You know, there are certain people who will not visit the hospital. They go on their own and take certain over-the-counter medications from the nearby medical shops. So that is how their immunity is being getting damaged. And you know very well that any antibiotic, if you have to preserve for them in future, you always need to do a culture sensitivity test. So you can see in this sensitivity analysis is always a helpful tool for us in order to quickly determine if bacteria are resistant or susceptible to your drugs. Example of this antibiotic resistant infections, most of you very well know, some of them keep repeatedly telling about a persistent sore throat or recurring urinary tract infections, or for any unresponsive case of pneumonia. Though you treat them, they don't respond to it. So always this can help your physician to see if the bacteria is causing any sort of infection which is very resistant. So they will be switching on to a different medication based upon culture sensitivity. Hope you understand. You're on the same track of my session. So how is the sensitivity analysis is performed? You all must know how this will be performed to your patients. For this one, if you see, a physician, as soon as they ask you to collect a sample, you must know what type of sample to be collected, when to collect, how to collect, what do you do after collecting this particular sample. So best examples you can say, most of the time physician will say that if it is recurrent symptoms are flayed upon your patient, they'll say, send the culture for a blood. So you should be able to take 2 sets of blood cultures from a different sites. If it is recommended from the 2 different sites, you will collect and send it across. Or urine, you must be very well know, a midstream urine must be a preferable one. And the sputum, you must know the spitting of sputum, cervix, a pus containing wounds. These are the common sites for collecting your blood samples. So when you are sending a blood sample to the laboratory, as we are an interdisciplinary team members, and we are a liaison between your patient and the patient physician. So when you become a liaison between a patient and physician, you must know the samples you should not get missed in between. That's the reason you always have to make sure this has been identified with the patient identifiers, and the proper site which you selected and the time of selection also you can mention. And the grown bacteria is known as a culture, and the bacteria in the culture will grow multiple areas. And you must know, after sending, you will be waiting for next to 48 hours to get your results. In this, you will be knowing whether it is a gram-positive cocci or a gram-positive negative cocci. So bacilli. So in this gram-positive cocci, most of you know there are certain examples. I can quote it over here. That is, the first one is Staphylococcus, Streptococcus, and Enterococcus. When you see this particular positive gram cocci into a microscope, it will be seen in the round in structure, and it will be like a dotted in structure. Whereas gram negative bacilli, if you see, that looks like, you can see this picture, it looks like in a rods. Okay, the rod shaped pictures you can see, then you will come to a conclusion it is gram negative. So the examples for gram negative, I can obviously say that is Pseudomonas, E. coli, Klebsiella, Enterobacter, and Acetobacter. These are the best examples I can be able to give for gram-negative bacilli. And what are the results for a sensitivity analysis? So now you have done a great job in taking the sample, sending it across to the lab, and now you're waiting for your results. And now your results analysis, you're going to see it in this way. So bacteria will form like a colonies with a large group of bacteria that will be exposed into different antibiotics. When you send it across to the lab, that is what a lab technician does. He'll take it and he will expose your sample to different antibiotics with different doses of antibiotics. Then you will know these colonies, wherever they are responding, then they will be calling it as susceptible. If they are not responding, it will be a resistant, or you can see an intermediate in response to the antibiotics. So the best example of your susceptible meaning, they cannot grow if the drug is present in that particular ton. So this means your antibiotics going to be very, very effective for your bacteria. So you can choose that particular antibiotic to treat your patient. Whereas the resistant means this, when it is there, the bacteria can grow even if the drug is present on that. So this is a bad sign of selecting this particular antibiotics. That's why we say it's a sign of ineffective antibiotic. Whereas intermediate means it's a higher dose of antibiotic is needed to prevent the growth of your antibiotics. So this is the old definition, I can say, SRI. Whereas now the UCAST guidelines, as per your UCAST guidelines or CLSI guidelines, they say they retermed it as an SIR, that is susceptible, intermediate, and the resistant. And we have discussed right now overall about your culture sensitivity. How do you collect your sample, and how do you label it, and when do you send it across to your laboratory? All these are few questions which are answered to you. Now this is the most important session into your today's session, you can say, that is overview on antibiogram. So when you wanted to have an antibiogram overview, first you must know how many types of antibiograms we have. So there are two types of antibiograms we have. One is hospital antibiogram and the patient antimicrobiome. So hospital antibiogram is very few. In one sentence, I can say, whenever you see that your hospital is doing very good and you must know even more to good, better. So you must be able to check what type of antibiotics are very resistive at your environment of hospitality. So that it's taken for the entire year, you will take it. Your results will be analyzed by your chief microbiologist, and they will come to a conclusion and they'll give you certain results. So for example, you can see here the susceptibility of E. coli to cefazolin is 60%. And if you use this empirical as an empirical therapy, as soon as a patient comes, by seeing the signs and symptoms of the patient, you want to start up a immediate shot of your antibiotic. Then based on this antimicrobiome of hospital, you will pick up. So you can see in this the chances of 40% failure. Here you will not be able to take your cefazolin for your E. coli because your failure chances are more. If it is less than 20, then you will be able to pick up that particular antibiotic as your empirical therapy. So you can see the benefit of picking up this empirical therapy is most likely to organism and the site of infection. Based upon your criticality of your patient, you choose the lesser failure rate of antibiotics. So the benchmark which I given for you this is 20% of failure of medications only you should be able to choose. Tracking the local antibiotic resistant trends so that we know what type of antibiotics are not really working in your hospital and reduces unnecessary prescription of that antibiotic. This is the overview of your hospital antibiogram. Go to the susceptible, as I gave you a new term as per your CLSI guidelines, UCAS guidelines, they have termed it as SIR, I said. So susceptibility, this susceptibility new in 2020 guidelines, they termed it as susceptible for standard dosing regimen. Means you have a certain standardized dose which is already fixed. So that particular dose only we should be able to give to the patient. So you have high likelihood for the therapeutic success. Whereas the I represent susceptible for increased exposure. Here, this particular like microorganisms are categorized to it. So antibiotic, whenever you choose this one, you attempt to increase the dose, so your infection rate will reduce. So here the standard dose will not work, but increasing dose will obviously give you a positive response in making the person to get better. So MSI value, this is the most important slide in your session, I can say, because based upon your MIC values only, you will be able to pick up your perfect antibiotic for the disease condition. So MIC is nothing but a minimal inhibitory concentration. So which is defined as lowest concentration of antibiotic, which is completely inhibit in vitro growth of your organisms. And you can say this values must be compared with MIC clinical breakpoint. I'll let you know in the further slides what is this MIC value and MIC clinical breakpoint so that you will come to an answer. So the third point says that MIC value is regarded to have this greatest importance in optimizing of your targeted antibiotic therapy. Is the best available parameters to reflect the effectiveness of your antibiotic against your bacterial strains. So you can see here, there is a one example I have given for your MIC value, and the right side, you can see your all antibiotics are presented. So each of this antibiotic have their own respective MIC values. And you can see in this whether it is susceptible or resistant or intermittently susceptible thing. So you can look into this particular report, you will be able to come to conclusions. Look at this clinical breakpoint. As I mentioned to you already, MIC values and the breakpoint values have a lot of importance in coming to a conclusion of choosing an antibiotic for your patient. So what is this zone diameter is nothing but when you send across your lab samples to your laboratory, there they will be putting into a slide. There they can see the diameter of your response. So that is based upon your zonal diameters. MIC breakpoints between your X and Y medications of antibiotic, you will prefer to choose it. And they ultimately you have a breakpoint of category. 3 clinical categories are SIR. One is SIR, I have already explained to you. So this MIC breakpoint quotient, if you see, this comparison done between two antibiotics, antibiotics X and antibiotic Y. So this what antibiotic X is explaining about. You can see in this antibiotic X, why do we say it is not very good for your people to choose it, whereas antibiotic Y is very good for choosing for your patient to have a better treatment. So one, I can tell you, breakpoint, you can see it is very closer to your MIC value. So it shouldn't be ever closer to your MIC value. Between your MIC value to the breakpoint, it should be a larger number so that you can choose that particular antibiotic as your preferable antibiotic to reduce your infection. So how long this to be given for your patients based upon the signs and symptoms and the response or hemodynamic stability of your patients, you should be able to choose your antibiotic for your patient. So I can see that is 14 days. Till this 14 days is the highest number of days you can use your antibiotic to be given to your patients. Or 7 to 10 days, if the patient is stable, you can give this one. Or community acquired pneumonia, you can continue the treatment for 5 days. Hospital acquired pneumonia, you continue to do the treatment for up to 7 days. Non-purulent cellulitis, you prefer to give for 5 days alone. So what is the sensitivity pattern speaks about? We have few sensitivity patterns speaks of. That is, one is pan sensitivity, multi-drug resistant strains, XDR strains, and pan-drug resistant strains. So what is this pan sensitivity? It means which is sensitive to all categories of your drugs. So you won't be able to do. So multi-drug resistant drug, there are certain drugs which are very resistant to certain antimicrobial agents. XDR strains, it is non-susceptible to at least 1 or 2 antimicrobial categories. Pan-drug resistance, non-susceptible to all the different agents in your microbial categories. You can see here, MDRO is nothing but multi-drug resistant organisms. You can see almost all the antibiotics, whatever is mentioned here, they are resistant to. You will be able to view in this all the microorganisms. There are multiple drugs which are resistant to. Go with your extremely drug resistant organisms. You can see very few, it's like I can say only 1 or 2 drugs you will be able to choose it from here. One is tetracycline, and the other 3 are 1I, 2I, and the second one you can see here, right? All these I's are increased doses. If you increase, you might get better results for your patients. And I'll be able to do a one case presentation here so that we will be able to view better into your results. So a patient with 45-year-old male presented with swelling, pain, and discharge from your left leg. Wound is associated with your fever again, and he's been a known history of diabetic, old CVA with seizures disorders. On examination, we could find that is a necrotizing fasciitis. The cultures were sent from the particular part, and the empirical treatment was being started with the piperacillin and tazobactam with clindamycin was started, and debridement was done. So what you are trying to get an answer from here is, first you must know what is the host factor for this particular patients. Once you know the host factor, then you need to isolate that particular organism. After isolating this organism, natural resistance, whether they are able to get developed by themselves or not, you check through. If naturally the resistance haven't come yet, then you will go for preferable antibiotic susceptibility report. That is what first slides have referred through. So after doing this antibiotic susceptibility report, there you have a source of control. Once you identify the source of control, then you will target your treatment. So once you target your site of concentration, you will pick up a particular antibiotic, whatever is choosing for your patient, whether it is a cidal one or a static drug. You will prefer to, after then you have to get into your beneficial, which should be with lesser risk. If you give a higher antibiotic, you choose to get a lot of side effects. For that reason, you should always look for lesser risk with higher benefit. Once you've taken this one, whether they are getting allergic to this particular medicine or not. If they are not allergic to this medicine, they find the pattern for your resistance. If it is not very resistant, choose that particular antibiotic. regimen and prescribe it to your patient with appropriate dose. So how do you know this appropriate dose? Based upon your culture sensitivity again? Yes, IR. Yes, of course, you have a standardized dose. You can pick it up. If it is I, with the increased dose, you will be able to get a better result. If it is R, prefer not to use that particular medication to your patient. So no improvement after 2 days, the fever spikes are persisting and the culture report comes like this. Now you'll be able to know what is susceptible to your patient, what is resistant to your patient, what is the in increasing of dose, you will be able to pick it up. So benzoyl penicillin and your oxacillin combinations are very preferable ones. You will be able to look into this and come to a conclusion to your gram positive infections and gram negative infections. Most of these gram positive infections, MRSAs will respond to ticloplanine and linezolid, vancomycin and daptomycin. MSSA is clindamycin with the penicillin group of flucoxylin will work on your patients. Whereas gram negative infections, carbapenems will be able to do better and beta lactam will be able to do better with fluoroclonide, amoxicillin. Then the last slide, which always mentions about your take home message, whatever we have discussed through so far, how it is going to be done, when it is going to be done, and how well you will be able to do this test for your patients. Once you do the test, what type of antibiotic you will be able to choose on your patients. All these things are going to give a better result for you. So take home message, I'll be able to tell you about the culture and sensitivity testing is performed to help diagnosis for an infection, and it may also help your physician to decide which medicine to use in treating the infections of your patients. So the second point always involves what type of test to be done for your patients. Some of the patients you might be taking your blood as your sample. Some of the patients you will be taking urine or sputum or the wound site or any one of the site which is infected. You will be picking up that as your site of sample collection. So as I mentioned to you already, the blood culture, whenever you send it across, as preferable, it is two sets are preferable ones with the different sites. Urine is a midstream urine. And if enough bacterial growth from the patient cultures, the best results you will be able to consider as positive. If there is no test, if it is positive, if it is not positive, then obviously 24 to 48 hours you will wait and consider it as negative. This makes it unlikely to have an infections. So based upon MIC value, as I mentioned to you already, again and again, I'm clearly mentioning it to you, minimum inhibitory concentration, that is MIC value, plays a vital role in choosing your antibiotic with breakpoints again. So the breakpoint categorized into SIR, susceptibility, increased resistant dose, and last one is R is resistance. The physician recommended to start an antibiotic as per the period of a time, whether it is 14 days or 10 days or 5 days or 7 days based upon the symptoms shown by the patients. So we come to a conclusion. So I feel that almost within 25 minutes, I covered the topic. The rest of 15 minutes, I will be able to give it to the audience. If at all you have any questions, you can type it in your chat box so that I'll be able to answer you. Thank you.
Thank you, Mrs. Jagruthi, for a beautiful presentation on the interpretation of culture sensitive reports and the antibiogram. So we have few questions here in the chat box which I'll read it to you. Starting from the first question. Yeah, so can you explain the basics of a report? So yes, if I go back to the presentation in that yes, this one. So for example, this is a report of Staph aureus, which is isolated, which is resistant to few of the bugs and few of the drugs. and is sensitive to many other drugs. So in the Staph aureus, we have two types, that is methicillin resistant and methicillin sensitive bugs. So MRSA and MSSA, which we commonly call. MSSA is sensitive to benzyl penicillin and oxacillin. So we have to see both the drugs here, whether it is sensitive or resistant. If it is resistant to either one of them, either benzyl penicillin or oxacillin, which will be reported by the microbiologist, it is MRSA, which means your normal drugs won't work. We have to go for the gram-positive MRSA cover. As Ms. Jagruthi has said, the linezolid, the teicoplanin, the vancomycin, daptomycin. Again, if you go through this report, what we get on the extreme left side is the list of drugs which is sensitive to this organism. In the middle, we get the susceptibility report, which is whether it is resistant or intermediate or sensitive, as explained by her. And the MIC value. MIC value here again is very important. We also compare this MIC value to the clinical breakpoints. So if it is less than or equal to 1 or 0.5, it is sensitive. If it is 2 to 4, depending on each organism and antibiotic combination, which is specified by the UCAST and the CLSI. Commonly follow the UCAST guidelines. So each one they give the MIC value on the right side, the susceptibility report on the middle side. So we can see whether it is S, I, or R, and then decide about the antibiotics. So coming to the next question. Yes. So how frequently do we do cultures in a sick patient? So a patient coming to ICU, we commonly send baseline cultures from the ER itself, from the casualty itself, and start them on an empirical antibiotic. We wait for the cultures for two days, 48 hours approximately, and then try to narrow down the antibiotic to a sensitive drug. If it is resistant, then we try to change the antibiotics. When to de-escalate or stop is, suppose if you get a patient who is very sick, who is in hypotension, who is in multi-organ failure, we try to stabilize the organs, we try to stabilize the BP. If the BP is stable for next 48 hours and is off vasopressor support, if the fever is not recurring for more than 48 hours and the organ failure has recovered and resolved, patient is holding on the BP and the oxygenation is good without any supports, then we try to de-escalate the antibiotics. We can also do a marker called procalcitonin, which if it is less than 80% of the value of the baseline, well, then we can de-escalate the antibiotic or stop the antibiotics. Coming to the cultures again, suppose if a patient comes from the ER, he's sick, we have started on antibiotic, we got some culture reports and we have started on some antibiotic targeted therapy, then we try to continue the antibiotic for 7 to 10 days. If at all during this period, if there is new onset of hypotension or a new onset of fever or raised white cell count or any new organ failure, then we try to increase the antibiotic and reset the cultures. So this is a method of going with the culture and the antibiotic reports. Coming to next question, what we have here is any role of prolonged use of antibiotics? Yes, there is a role of prolonged infusion of antibiotics. Commonly sensitive bacteria, we give the standard dosing for 7 to 10 days depending on the response. Resistant bugs and intermediate resistant bugs, we try to give a prolonged infusion for 3 hours, especially in antibiotics like meropenem, colistin, and ceftazidime, avibactam, and aztreonam, and they should be given in combination along with each other. So prolonged use of antibiotics for 3 hours duration is very important. Otherwise, normal sensitive antibiotics we give over a period of 30 minutes to 1 hour, depending on the response, and after test dose. This one, will you answer, Mr. Jagruthi? Any role of obtaining cultures apart from patient, like from the ICU services or the OD services?
Yeah, as per the new CDC guidelines of 2020, you can go through that. Most of us know that we need not take any cultures from the OT or the ICU surfaces, but no, we can even say that in case if you have any sort of infections, it is recurrently coming into the ICU or the OT, then you will be able to prefer to do one particular test based upon the requirement. So, and you can say this monitor to monitor the potential and hazardous conditions also in a bioaerosols and quality assurance, for especially for your quality purposes, in case you want to prove that your surfaces are neat and clean. For that also, to evaluate the effectiveness or the changes, you will be able to do this one. If not, the CDC guidelines recommend that you need not do any one of these tests except for the terminal cleanings. And what are the measures to prevent healthcare associated infections? As you all, most of you know that this is the common thing is hand hygiene to be performed. So when you know hand hygiene to be performed, the 5 moments of the hand hygiene is the first priority. Aseptic techniques to be taken up, and your all infection control bundle checklist like your WAP, COTI, and CLAPSI or SSI bundle checklist have to be performed. And when you perform this type of antibiotic checklist also, you make sure that insertion and maintenance checklist, you will be noting it. And what happens when the prescribed dose in substantial or course of therapy is not completed? Obviously, you can see that there will not be much of results you will be able to see in that particular patient, but you will may not be preserve that particular antibiotic for the near future of your patient. That's why you have to complete the entire course of your medications and make sure that emergence or resistant bugs, whatever you have, which will be persistently performed there, inadequate clearance of infection, persistent sick state of the patients, and propensate to your develop of the other organ involvements like organ failures. Look into that.
So the next question is about what are the measurements to prevent healthcare? This is over, right?
Yes.
Okay. What are the common sites of gram-positive, gram-negative infections? So gram-positive infections usually we face in the superficial surfaces like skin surface, subcutaneous tissues, and soft tissue infections, and even the post-surgical infections. Like your abdominal wounds or any peripheral wounds after the amputation and all. Gram negative commonly we see during pneumonia or your bloodstream infections or catheter associated infections or the UTIs. So these are all the common gram negative infections we face in the ICU. There's one more question. How can we adjust the antibiotic dose in liver failure and kidney failure patients? So usually the liver failure patients, if there is no particular criteria for titrating the dose in liver failure patients, if they come with a thrombocytopenia or any other infection, if they come with thrombocytopenia, we avoid certain kind of drugs like magnexfort and a few BLBLI combinations. Otherwise, in your and the antitubercular drugs also we avoid in the liver failure patients. Otherwise, it is safe to have other drugs, commonly used ICU antibiotics in the liver failure patients. Whereas in kidney failure patients, yes, we have a criteria. We calculate the creatinine clearance. Daily, we calculate the creatinine clearance and try to adjust the antibiotic dose according to the clearance. We can even take the help of the nephrologist or the intensivist or the clinical pharmacist for the dose adjustment in a kidney failure patients. And we also should be remember that the bedside nurse, we should repeat the certain antibiotics like cholesterol, like vancomycin after the dialysis, because the dialysis, it is this dose of the antibiotic what we're giving before dialysis is washed by the dialysis. It's cleared by the dialysis technique. So we have to repeat the dose of these drugs after the dialysis. One more question is, any protocol for changing the lines and catheters in a patient coming from outside healthcare facility to our unit, and when to send the cultures in such patients? So yes, we when we assess the patient in the ER, we try to record the BP, the vitals, and we try to assess the history. If there is if the patient is receiving some antibiotic outside and his condition is sick, we try to escalate the antibiotic. I mean, we need to increase the dose of antibiotic and the other antibiotic to put, which is higher than the existing antibiotic if the patient's condition is very sick. And if he has a existing catheters like a Foley's catheter or a central line or a ET tube, we try to change the all these devices in the ER. And after changing, we need to send the culture from the fresh lines, and then adjust the dose of antibiotics, increase the dose and the therapy of antibiotics, and wait for the cultures, and then titrate the antibiotics and optimize the antibiotics according to the condition again. One more question is how to calculate the MIC breakpoint. So breakpoints, what we do is we have three methods to calculate. First one is the Kirby-Bor disc diffusion method, where they put a battery inoculum and the antibiotic, and they try to measure the zone of inhibition. that will be done by a microbiologist. And the second method is the broth microbiologist method. We have not included because it will be difficult. It will be difficulty understanding in that techniques. So then second thing is this broth microbiologist method, where they put increasing concentration of antibiotics in the successive test tubes and try to see the MIC. If it is inhibiting at 2, that is 2 microgram per liter, that means the MIC is 2. And then we have to compare these breakpoints with the clinical breakpoints established by the UCAST. Third thing is by the gradient method. We have a strip with loading of antibiotic to the strip with a specific concentrations, where we put the gradient, where we put the strip in the broth and try to see whether it is inhibiting at what concentration level. And then accordingly we can calculate the MIC breakpoints. So yeah, one more question is, catheter tip can be sent for the culture? No, it is not recommended, because you usually have a colonizer there in the catheter tips. Even in the Foley strip, even in the central line tip, you have a biofilm there, which is formed by the colonizers and the commensal. So it's not recommended by the CDC to send the catheter tip for cultures. It is a bad practice. If you want to send the cultures and do a surveillance, then you have to take a proper sample, blood sample or urine midstream sample, as explained by the speaker. One more question is, what is the role of CRP in? Yes, again, what I discussed here is CRP and procalcitonin both are the markers of inflammation as well as markers of sepsis. So in patient who you want to monitor whether our therapy of antibiotics is working or not, we can do CRP either daily after 24 hours or after in alternate day frequency, and we can monitor the CRP levels and the procal levels. If your CRP levels are decreasing, that means the inflammation is coming down and the sepsis is in control. If it is increasing, then you need to be very cautious and again try to see whether it is only an inflammation or a sepsis going on. If sepsis is increasing, then you have to repeat your cultures and you need to see whether it is actually bacterial infection or any other existing gram negative or gram positive or any other fungal infection. Even the procal, we try to send the procal at the baseline level just to monitor how what is the level. Suppose it is at 30, and if the after therapy of 7 to 10 days, if the procal levels is decreasing to 2, that means it is reducing more than 80%, then we can de-escalate or use or they can stop the antibiotics. So definitely there is a role of procal and the CRP in the monitoring of sepsis and your treatment for antibiotics. I think we are done with the questions also. Yeah. So one more question is, why do we give stat doses followed by regular dose? Is stat necessary? Yes, stat doses of antibiotics is necessary because to maintain the therapeutic level of antibiotics. Suppose if, for example, I'm giving a meropenem, the usual dose is 1 gram TID. Depending on the conditions. So I try to give a stat dose of 2 grams, double the dose, so that I try to maintain the plasma levels of the meropenem at a certain level, and then I try to I try to achieve that plasma level of a certain level, and then we need to maintain that level at particular above that particular level. So we try to give a stat dose of 2 grams followed by 1 gram TID, so that concentration is maintained in the plasma. Yeah, one more question is, why the antibiotics are given as slow infusion? Yes, to prevent any anaphylactic reactions or any drug interaction or any effects because of the giving in higher dose or higher in fast infusion, that may cause vasodilation, or some antibiotics may cause the anaphylactic reactions and hypotension. So to prevent those things we do. And I already explained the dose, like some antibiotics are given over 3 hours to increase their time dependent concentration, and we need to give them in 3 hours so that resistant mechanisms are controlled and they try to inhibit that.
What is the criteria for selecting an antibiotic? So we have already seen in the MIC value, that is how we'll be able to pick up an antibiotic. So based upon your UCAS guidelines and CLSI guidelines, you will be able to pick up, as the doctor already advised you to go through this different types of methods, of 3 different types of methods. Based on that, you have to pick up, because gram negative and gram positive, both of the medications are differs. So if you don't select at per this particular criteria, so since we have another 10 minutes, I expect any one of you have any questions, you can please post it in the chat box. Some of you who have doubts about MIC breakpoint questions, you can read through, because these are few self-explanatory slides.
One more question is there: in vivo and in vitro concentration non-responsiveness. So in vivo means, for general public, I need to say that in vivo means it is the body what is being monitored in the patient's patient himself. In vitro means when we are doing the concentration and we are doing the MIC values, and when we are doing the response of antibiotic in the broth or in the culture medium in the microbiology lab. In vitro means in the lab. In vivo means in the body. So yes, there is definitely the response will be different in vivo and in vitro, because in vivo we try to in vivo we have to take in account the dose what we are giving, the patient's pharmacological PKPD parameters, there is pharmacodynamic and pharmacokinetic parameters, and the patient's the clinical response, how he's responding. There may be any other organ failures also. So we need to take all those parameters into the picture, and then try to treat the patient. It is not simple like treating or inhibiting the bacteria in the organism in the lab. So we need to take all these parameters, and then because of these multi-organ failures and less therapeutic dose in patients with AKI and the liver injury, they respond very, they respond late, and they may not have a good response compared to what is being achieved in the in vitro.
So the next question, can you please once again explain about the breakpoint? As the doctor have advised, already instructed you, that is lesser the number, that is in antibiotic X and antibiotic Y you have here. So preferably antibiotic X is not choosable drug. The reason is it is closer to your 0.50 or near to this. The MSC value to the near one, it will not have a better result on your patient. That's why your MIC values to break point, it should be larger in number. You can see here 0.5 and the 1, which is not very closer. It is very closer. And the other one, if you see, it is 2 to nearly to the 16 points it is coming. So the antibiotic Y may be a preferable antibiotic. The reason it is acting on your patients effectively because of it. Hope I'm clear. If not, I'll be able to repeat it again. And the next question, how much time is needed for bacteria to become resistant strain like MDR or XDR? So I have already mentioned to you, it is 24 to 48 hours is your minimal culture sensitivity time. Within this time, if it is shows that is an MDR or XDR, that is, I think that has been.
Yeah. So such things. I'll read out that question again.
Yes.
How much time is needed for the bacteria to become resistant strain like MDR, XDR? Yes, as soon as you start an antibiotic in a patient with subtherapeutic dose, suppose the dose requires 2 grams and you're giving 0.5 grams or 1 gram, the bacteria tries to develop some resistant strains in them. They try to develop mechanism of resistance in them, like they try to change the site of action on the bacteria surface, or they try to develop some pores, and they try to expel the drug out of that pores from the bacteria inside the bacteria. So as soon as you start a drug, subtherapeutic dose, and you take antibiotics at less than optimal duration. Suppose the duration is mentioned for 7 days, and you try to take only for 3 or 4 days without any response. Next time when you go for a culture, you may get a resistant bacteria there. And usually MDR and XDR bugs are seen in hospital-acquired infections, not in the community-acquired infections. Community-acquired infections may be XDR, MDR, but in that the patient may already might be taking some antibiotics previously, or they may have an exposure to antibiotics in the previous healthcare admission. So that may lead to the XDR or MDR bugs. One more question is why don't we stop using antibiotics and start targeting DNA bacteria? That I think for that we need more research purposes, and we cannot, still we need to go more about in depth in that. As of now, we try to just target the antibiotics and target the bacteria, not the DNS. So how will we come to know growth of bugs is from lines if both the cultures showing growth with different organisms? So time to dependent concentration is there, where you have to take the cultures from 2 lines 1 hour apart. If both the lines are showing if both the cultures are showing antibiotic, if both the cultures are showing some growth in the bacteria, that means within the 1 hour, that means it is a culture from the lines. So you have to remove both the lines and then secure fresh lines. And we also try to take a culture from the line and one from fresh line, so that we need to compare. If it is growing from the line, it means that there is some colonization or a commensal growing there. If it is growing from the fresh line, it means an actual infection. So one more thing, where there is no only MIC is given on the report, there is no breakpoint. This is a very good question. Actually, for the breakpoint, usually the labs don't report the breakpoint in the sensitivity report. The breakpoints are given in the UCAS guidelines on the website. You can go and check there. The microbiologists, they usually interpret those breakpoints and compare with the MIC values and give us the report whether it is sensitive or resistant. These breakpoints are usually established in the automatic system. There is a Vitek2 system what we are using nowadays in our healthcare facility. So those MIC and breakpoints are compared, and they just give us a report whether it is sensitive or resistant. Breakpoints are different for different antibiotic and organism combinations, so they cannot mention all those breakpoints in the report. They just mention the MIC value, and for us, most important is whether MIC is less or more. That we'll see. One more question is, in culture reports, what is the importance of cell count? Yes, usually the cell count, what we see is it should be more than 10 to the power of 5 for a significant growth. If it is less than 10 to the power of 5, like 10 to the power of 3 or 100 or 1000 or 10,000 counts, usually it is called insignificant growth. It may not be harming the patient. We may need to again, see the surveillance cultures again. It may not be significant. Like, for example, in UTI, if you have the patient with a growth of 10 to 3 or 10 to 4, they may not be manifesting any symptoms. So you may not treat the patients and bombard them with antibiotics. Just see the clinical picture and then try to treat them. Yeah, one more question. So less the MIC, high is the susceptibility in general. Yes, the MIC values we cannot compare between two different antibiotic groups. Suppose it is, for example, I am comparing a BLI with a meropenem or carbapenems. I cannot compare these two MIC values. I have to see within the same group whether the MIC for meropenem or imipenem or doripenem or biopenem is the same, which is more sensitive. I can compare. I cannot compare the MIC value with the MIC value of two different antibiotic groups. Within the same antibiotic group, I can compare. So one more question is this a thumb rule for MIC to follow? Yes, it's not. It may not be a thumb rule, but definitely we should see the patient's clinical condition. We should assess all the parameters, and MIC definitely is more important in your culture reports. And in this within the same subgroup also in the antibiotics, suppose I'm using a BL-BLA combination, I'm using a cefoperazone and a piperacillin-tazobactam. If it is resistant or intermediate to either one of them, I cannot use the same BL-BLA. I have to go to the higher antibiotic like a carbapenem.
What is clinical criteria to select an antibiotic if the cultures are sent later?
Yes, usually we try to send the cultures before starting the antibiotic, but it is not a hard and fast rule to wait for the antibiotics and send the cultures. If we are able to send cultures within the patient coming to the hospital of within 1 hour, then it is okay. It is acceptable. If it is getting late for the culture bottles, or if we don't have a culture bottles available, then we should not delay the antibiotic. Antibiotic should be given within, as per your sepsis guidelines, should be given within 1 hour of the recognition of sepsis. And yes, if later on also, if you start the antibiotic, yes, you can send the cultures. We may not get a growth, but definitely if depending on the condition, if the patient responds to the antibiotics, you can de-escalate the antibiotic based on your biomarkers, as I said already. So 5 to 7 days of antibiotics you can give, or you can even you can even try to send cultures later on before stopping the antibiotic also. If you get a growth again there, then you can change the antibiotics there. Otherwise, you can stop the antibiotic based on your clinical response, and even on your based on the procal and your biomarkers like CRP.
So the last 5 minutes for the questions. Thank you so much for the opportunity given to me for the entire ISCCM academic chair and the other STEPN team members, with all the hospital team members, and Dr. Saud for being my moderator for the day, and the hospital team members, including Dr. Ramesh and Madam Bobby Ramesh. Thank you once again.